Hi everyone, this is the first webinar in NASDAQ's 2018 PrEP Financing and Access Series. For today's webinar, we are going to cover issues related to financing linkage and retention in PrEP care. Again, thank you for joining us. I'm Edwin Corbin Gutierrez, manager in the Health Systems Integration team here at NASDAQ. Before we go into formal introductions and dive into presentations, I want to cover just a couple of logistic items and give you a little bit more information about the series. In terms of logistics, you're welcome to use the audio connection on your computer or dial in if the quality of the audio is not great. The call-in number and webinar ID are on the screen. We've asked our presenters today to keep their presentations brief so we have time for discussion. But given the number of participants on the webinar, we are going to ask you to submit questions for our presenters using the Q&A function. The function is on the right of the menu bar in your Ring Central window. If you don't see it, it might be under the More icon on the right-hand side of the menu bar. To contextualize today's conversation for new participants, NASDAQ's PrEP Financing and Access webinar series showcases strategies that health departments and community health providers have developed to finance PrEP programs. That includes decreasing disparities in access to the intervention and evaluating PrEP access. So far in the past year, we've discussed PrEPcost.org, which is NASDAQ's health plan finder for PrEP. We've talked about confidentiality and consent considerations for minors, strategies to engage providers in PrEP insurance and benefits navigation training in Colorado, teleprep in Iowa, online PrEP navigation with pleaseprepme.org, and the PrEP drug assistance programs in Illinois and Washington State. So with that, let's dive into our session today. You see on the screen the information to get access to the webinar recordings and materials that our presenters have shared. Today's webinar focuses on linkage to PrEP care and retention support services, which are key components of most PrEP implementation models. We know that financing these support services can be a challenge for public health programs. So today's webinar will discuss how health departments are leveraging the Ryan White HIV/AIDS program to provide essential support services for PrEP candidates through early intervention services, health education, and risk reduction and outreach. The three service categories that our first presenter will be focusing on. And we'll also discuss examples of cutting-edge linkage and retention support strategies, such as online reminders, which can be deployed across clinical and community settings to support PrEP clients. So these are our three learning objectives. And finally, I just want to introduce you to our speakers. First, we have Pedro DeMartino, who is the Center Chief in the Department of HIV Prevention and Health Services in the Maryland Department of Health. And Pedro Alonso Serrano is the Project Director at the Hektoen Institute in Chicago, Illinois. He is a public health researcher with experience directing epidemiological, behavioral, and clinical trials using mHealth strategies, focusing on HIV prevention with gender and sexual diverse adolescents and young adult populations. So with that, Peter, take it away. Let me know if you need any assistance with the screen share. There we go. Great. Perfect.
There we go. Hi, everyone. Thank you for the opportunity to NASDAQ. And just before I get started, I want to thank my team, which has done a tremendous amount of work to work towards expanding how we deliver services to undiagnosed individuals in Maryland. So I'm contractually obligated to start with the mission and vision of the Prevention and Health Promotion Administration, which our Infectious Disease Bureau is a part of. We always like to focus on the fact that we provide leadership, but leaders are only as good as their partners. And of course, our services are all geared towards vulnerable populations. So we started a program that we call Upstream. Um, about 2 years ago, we went out and visited all of our Ryan White vendors and really talked to them about how they could expand their activities. And one of the things we really started to focus on was the use of outreach, EIS, and HERR for undiagnosed individuals. And we're very careful about that language of undiagnosed individuals. And we'll talk a little bit more about how we got there. So why did we start our Upstream program? We were really looking at the goal of the Ryan White program. For us, we interpreted it as getting everyone to a suppressed viral load. But in order to do that, we have to step back and look at this population that is undiagnosed, that are living with HIV, and how are we accessing them? How are we bringing them into our services? And so, of course, we started looking at the National HIV and AIDS Strategy and looking at what their goals there were, and of course, looking at reducing new infections and ensuring that everyone has access to care. But more importantly for us, we as administrators started looking at the fourth goal, which is achieving a more coordinated response. And that's where we started looking at our traditional prevention programs in Maryland's context for our 5-year integrated plan. So you'll notice under our vulnerable populations, which expands the continuum, we have PrEP and NTEP as one of our primary activities. And so we were looking for ways to support that with the current infrastructure in our 24 health jurisdictions across the state in particular. And that's where we started thinking about how the current Ryan White program works. And our Ryan White system has always been downstream. So this little patch of fire down there is really the diagnosis, and even more so the eligibility for the Ryan White program. And then in many ways, we've created a system that is a crisis management system. So we're interacting with individuals when they are in a time of need. And we really started to look at how do we think more upstream? How do we keep people negative if they are negative? And how do we get people diagnosed in such a way that we're not managing crises as often as we have been? So we were looking at how do we get to folks pre-diagnosis? Could we suspend eligibility? And most importantly, did our partners have the capacity to expand their efforts to include this change in their approach? So we brought together outreach, early intervention, and health education and risk reduction because we felt like that gave us the best opportunity. And I will say that one of the biggest issues even in our second year of the program is understanding that, yes, you can use Ryan White for undiagnosed individuals. We started to understand that if undetectable truly is untransmissible, then that is the goal. And that if we could diagnose everyone, get them into care, keep them into care, and get them to a suppressed viral load, then we really were doing the work of prevention because there would be less folks out there able to transmit the virus. But first, we had to find our 6,600 undiagnosed in Maryland. As we looked at other models, of course, we looked at New York and their status neutral continuum, and we call it the magnetic continuum because we feel that positive or negative, you should have access to the same level of service. This is a tough one for both my staff, for other parts of the health department, and particularly our vendors and the community somewhat to understand, because this means an intensity of service equivalent to what you receive in the Ryan White program. Because if we're saying that folks who are undiagnosed are eligible for Ryan White services, then they should be eligible for the same intensity of service. And what comes with that is also the same intensity of data collection. So I think those are two big issues we've been grappling with over the past 2 years, is that intensity of service and that intensity of data collection. So again, we looked at these three categories and ideally wanted to fund our vendors for all three categories at the same time and built the program that way. So our ideal program was we would define our priority population. And here, of course, if we're talking about ideals, we might as well use Disney characters. So our ideal would be that we would identify this is the population that either in the National HIV/AIDS strategy, and for us in Maryland, NHUS 2020 identifies everyone in the southern states as a priority. So that means everyone who lives in Maryland becomes a priority population. We would create an outreach program that would meet people where they are, meet their needs, and be attractive. We always want our programs to be attractive and have the appropriate tools to guide people. I'm using Merlin from The Sword and the Stone very specifically for our early intervention services, not just because his wand looks like an Orashore, but because he was a shape changer. He changed his shape to meet the needs of what was happening. So we feel that our services, when folks are entering into EIS, we of course have to meet them where they're at. And that means a variety of activities and referrals. So HERR, moving to flora, fauna, and Merriweather, providing the appropriate gifts for, of course, when we have the dragon show up. So that's my silly little slide of what the ideal looks like. So how this actually works, here's the more governmental slide. You have your priority population, you're doing your outreach at times and places that are important, you're using your early intervention services for testing, and then of course you're moving people into health education and risk reduction. The red arrow shows where you move out of Ryan White funded services. So how we've done this for PrEP programs is we've identified our priority populations, you're doing your outreach work to link them to care, you're doing your EIS for that initial HIV test, that initial care planning, if that needs to happen. And then if they are a PrEP candidate, you're stepping out of Ryan White eligible activities where you're dealing with your PrEP prescriber, your prescriptions, and your ongoing labs. And then of course, once they're on PrEP, you're moving them back into Ryan White eligible services where they are receiving the treatment adherence they need. So we had a little difficulty with HERR because we had staff and we had vendors who felt very strongly that they understood what HRSA meant when it said partner. There were conversations about it had to be, you had to have someone in careware that was their identified partner. We also had people say you had to have the Ryan White recipient in the room at the time that the partner was receiving services. And of course, that's not what we're going with in Maryland. We are really feeling like HRSA has given us the guidance, and particularly when we're talking about places like Baltimore, where we have a 1 in 43 lifetime risk of acquiring HIV, we are assuming that there is background prevalence for our priority populations, that we can assume there was a Ryan White eligible partner at some point in their history. And so we are expanding this definition for us. We developed core elements, basically saying that you must be providing services to a vulnerable population, and it must be a significant enhancement to existing HIV services, and that it may not supplant existing funding. So this gave us what we felt was the authority to suspend eligibility. So our eligibility here is you are part of a vulnerable population, and that's it. So we're not doing financial screening on individuals for outreach and EIS or health education and risk reduction. So this came at a very timely period for us because in Baltimore, the 1506 contract was reduced by about 55%. And so we were able to actually take the 1506 activities, and we very specifically focused on Star Trek, which is our adolescent youth health program at the University of Maryland, Baltimore. And so they do programming for 12 to 26-year-olds and had been doing lots of activities under 1506. And so we actually assumed that entire contract. So we didn't give dollars to Baltimore City Health Department to implement. We actually took over Star Trek's contract and then mapped everything they had been doing under 1506 to Ryan White eligible activities and also the data collection to CareWare. This was not the easiest process. We are still going through figuring out how do we collect data in CareWare for a beauty night for trans individuals and gender non-conforming individuals. So again, that intensity of data collection is something new for a lot of our traditional quote unquote prevention vendors. And it was really important to us that all of the data collection should be integrated into CareWare, even though we're using rebate dollars. And we wanted to ensure that we were not replicating CDC requirements. For example, we didn't mandate that you had to use a CDC triplicate test form for all of our EIS tests. That has been an issue for some of our vendors as we expand, particularly those vendors that we have been providing indirect funding or indirect support, meaning we had been providing test kits to them but not staffing. So we actually had about 1,000 EIS tests reported to the CDC this year, just because folks went ahead and used the triplicate test form. So that's been an issue. With outreach and EIS, we've also had lots of difficulty understanding a contact under outreach becoming a deeper encounter under EIS and being an ongoing engagement with health education and risk reduction. So for outreach, we have one level of data collection. It's a light touch. For EIS, we have a deeper encounter where we expect more data variables to be collected for CareWare. And then for health education risk reduction, it's almost a level of case management, just about a step below having a full-on medical case management, non-medical case management care plan. So as we looked at the data we've been collecting over the past year in particular, we recognized that we went with the middle plan when we built our CareWare system, so that there would be that red EIS encounter that would always be the initial activity that was recorded with additional outreach and a test as a subcategory. What we found out is that there are lots of vendors who are providing outreach with referrals into EIS, and some EIS providers are only recording the test as the primary activity without an EIS encounter. This is not an issue we have solved, and we are working with each vendor individually to clear up how they collect their data in CareWare. The last thing we recognized, particularly as we look back at 2 years worth of data, is not everything is our upstream category. So for example, we have MAI outreach as well as now upstream outreach, two different populations. For many, our MAI is very specifically African American, so they may have built an upstream outreach program based on their MAI outreach, for example, Latinos. We also have issues around HERR because we've been using some HERR categories for treatment adherence. And so we've had some data collection issues there, as well as the EIS testing data. The testing data has really been the most difficult because CareWare is not the most conducive to recording testing, and actually recording services for negatives can sometimes be a little difficult in CareWare. So that gives us a general overview of where we are in the state. It has been successful, but there are definitely some programmatic challenges, particularly around data collection.
Thank you, Peter. As we transition to Pedro's presentation, and Pedro, feel free to share your screen. I just want to remind everyone that we'll be taking questions through the Q&A function. So please feel free to start sending us your questions.
Hi. All right. Well, thanks for that segue intro, Edwin. So I am Pedro Serrano, and I'm here in Chicago at the Hektoen Institute and the Cook County Health and Hospital System um, as a project director on NIH-funded research studies under Sybil Hosek at the Cook County Hospital. And I'm focusing on the outreach and engagement portion of this webinar. Um, so whereas Peter gave you a broad look at how they've been able to utilize their uh, funding to structure their PrEP program, I'm more specifically focusing on the outreach and piece of that, and specifically speaking from my experience on HIV prevention and PrEP clinical studies that we've run here in Chicago and other parts of the US. So a bit about me. My work has been in community engagement of young people, young gender and sexual diverse people, focusing on activities like health education and PrEP outreach, as well as advertising and marketing of PrEP. If you've seen the PrEP for Love campaign, that's something that we collaboratively put out here in Illinois, as well as recruitment and retention into PrEP trials. My formative work began with the Adolescent Trials Network, a qualitative research study that we conducted with young men who have sex with men in regards to their masculine, ethnic, and gender identity. And then I moved into clinical trials under Sybil Hosek and the Adolescent Trials Network with the young men who have sex with men PrEP trials. Lastly, with 113, which is the study that the FDA is now evaluating to see whether we can lower the age indication for PrEP. We also collaborated with IPREX study. We ran the open label extension here in Chicago with young men. And we've also worked with ALU and the EPIC randomized control trial, which I'm presenting a little bit of data from here to illustrate the use of some outreach strategies and the change and impact that they have in your clinic retention. We're currently running the Gilead Discover trial, the HPTN 083 injectable, long-acting injectable trial, as well as many mobile sexual health studies through the ITEC Adolescent Trials Network group, as well as a newer cohort study some of you may have begun to hear about called LIGHT studies. These are large cohort studies that are looking at, for example, tracking HIV risk and protective behaviors and HIV status across MSM throughout the US. So there's two trials coming out of New York tracking. One is tracking 8,000 individuals. The second one is tracking 5,000 individuals. Here in Chicago, we're tracking 3,000. And there's another trans women specific cohort that I think is just launching out of Baltimore actually, and a couple other cities tracking trans women's HIV behaviors and HIV status. And I'll be speaking to you about how we employ online strategies to do this work, this tracking work, without ever meeting anyone in person. So we're going to be focusing on this third of the learning goals for today, which is looking at, again, the engagement strategies and retention strategies. So a bit about how we've implemented online engagement strategies through the different studies we've run here over time and how and why we went with those strategies. Um, Back in 2009, when we ran the first ATN PrEP study, 082, we were working with 18 to 22-year-old young men who have sex with men, and as well as some trans women, young trans women. Um, Generally, most of these studies have been a greater majority of people of color versus not. Um, and we ran with the traditional outreach approach of street and bar outreach. At that time, Chicago actually had several 17 and up parties uh, for young people, and we would do the traditional outreach method of approaching young people, asking them if they were interested in participating in a sexual health study that involved the use of a novel approach to HIV prevention at that time, PrEP, um, and everything it took from having to explain what that concept even meant of taking a pill that may prevent HIV, um, and getting them through the door. So that was where our work began. And in 2009, services like Grindr they weren't as big as they are now, so we weren't using those strategies. And I think if you speak with your staff at your departments, your outreach staff, and get an idea of the amount of time it takes to do street, bar, venue-based outreach, and the amount of impact you get out of that, um, it's very labor intensive, very time intensive, and that's what we learned through that work on that study. Um, so that by the time that 2012 rolled around and we were working on the national ATN 110 and 113 PrEP studies for 15 through 22-year-old young men who have sex with men and trans women, we began using online advertising through Facebook and Grindr and other similar social media services to one, um, educate this population about what PrEP was and interest them in what it could do for them, and get them to engage and come in for PrEP research. Um, I'm not so. We went from being on the street, going up to people to ask them if they'd come into clinic, to putting up social media posts and advertisements online to get people in the door. And what we saw was a drop in the amount of time and effort it took to reach people, and an increase in the amount of people who are actually interested and willing to come in and participate. So that right there showed us that online advertising was the way to go when it came to um, advertising PrEP to this particular population, and that it was effective. During EPIC in 2015, this is a study with Al Liu in San Francisco. We demoed it, we ran the randomized control trial here in Chicago with a wider age range of 18 to 29-year-old men who have sex with men and trans women. And we implemented a bidirectional texting retention program. So we had half of our group, I think it was 2 to 1. So we had about 2/3 of our group had access to this bidirectional texting with their provider about their daily text reminders for their PrEP, as well as open discussion about other PrEP related issues, side effects, etc., and even appointment reminders. And we had a group that did not have access to that. They had standard of care, which was basically phone call appointment reminders and no pill reminders coming to them from some automated system. Um, Lastly, the studies that we've recently launched are using combinations of online advertising for recruitment, as well as texting for retention support. Um, so these are a couple slides that illustrate in the light blue versus the dark blue, the patients who were retained for their PrEP appointments, who had access to that bidirectional texting PrepMate platform, versus those who were only being called to remind them of their appointments. And so a greater proportion of our study cohort came in for their appointments and kept their appointments over a 9-month period versus those who did not have access to that. And that actually also was true for how many of them actually had detectable or protective levels of Truvada based on dried blood spot testing. So those who had access to the PrepMate texting feature also had higher levels of detectable Truvada versus those who did not, which really just speaks to the importance of providing your patients with tools that work for them when it comes to remembering when their appointments are, being able to reach their provider when they have questions about their, medical regimen, the PrEP regimen, and actually, taking their PrEP. So I've spoke about this a little bit, but when we talk about outreach broadly, the traditional method has been the street and the venue based method of meeting people where they are literally, popular places that they visit that that you'll find the audience that you're looking to work with. But more recently, effective outreach strategies combine both the traditional approaches and newer approaches that are now available to us as technology changes, including online advertising, social media marketing, and in particular geosocial advertising, which is basically zip code based advertising. So you can be very targeted in not only the population that you are attempting to do outreach with, but also where they are. So what does online outreach look like broadly? Of course, so if your agency has a web page or site, or maybe it has a mobile app as well, that is really the core of your strategy, is letting people know, letting your audience know, your target population know who you are, what you do, what services you offer, logistics of where you're located and when you're open. But if it's a good idea to work with your IT department, your IT staff person, or maybe a consultant that an IT consultant, to make sure that that website is optimized for mobile devices. Many, especially young people, they're not looking at your agency's website on a laptop or a desktop. They're looking at it on their mobile phone. So making sure that it's optimized for mobile is very important. Making sure that search engines know how to find your website is important. And I know that that's something that most people wouldn't even consider. But if someone, let's say in Atlanta, is searching HIV testing, Atlanta, you would hope that your agency comes up as one of the top, 3, 5 options. And if it's not, that means that it's not optimized to be found easily when people search for services near them. So that's an important piece too. The difference between online advertising versus social marketing is really the difference between posting general audience advertisements on a platform such as Facebook. You could consider that a general online advertising approach versus social marketing, where you're targeting very specific audiences on very specific platforms, like something like running an ad on Grindr. You're really only reaching men who have sex with men primarily on a specific platform. And how all these strategies move from outreach to engagement is offering your intended population additional ways of getting a hold of you, not just a telephone call, but providing them with perhaps video messaging, chat, and text options as well, which is something that I'm going to speak about now. So if your agency maybe doesn't yet have, maybe you're funding a community-based organization that they themselves don't have a web page or a website or a very functional one. Services like WordPress or Wix have fairly low cost per year services that are very do-it-yourself friendly for building web pages. And in regards to the social media marketing piece, um, many offer will counter with, I don't know how to run an effective marketing campaign, or I'm not familiar with these tools, or it seems, labor intensive to post to these different channels on a daily basis. Well, there are actually now marketing management applications like Hootsuite, which is basically uh, posting once and then having it be cross-posted automatically for you. These are the types of things that I would say applications and skills that you would look for in hiring a department or staff or staff person to do this type of work. You would want them to be familiar with these types of applications and tools. The nice thing is, so moving on to particularly talking about communication contact centers, which is what they call like messaging platforms. Um, Not only are there commercial platforms that are already available, like MedChat or VC, which many I've seen, at least in research studies, I've seen them being used as vendors. Those are pretty much ready to go. If you have the budget to include those types of options for your PrEP patients and PrEP clinics, if your institution doesn't already have these types of communication channels available for your patients, then you could certainly use these vendors if you could include them in your budget. But if not, there's also much lower cost academic and research oriented platforms that are also been trialed. In particular, I spoke about PrepMate, which we built for the EPIC randomized control trial, as well as for a different uh, PrEP adherence study called A-Team, which we have here in Chicago. Jonathan Fuchs in San Francisco is actually working with his developer for PrepMate to be able to license it out to interested clinics or other community agencies. So if that is something that you're interested in, I did include links throughout the slides, which once you are able to download them and access them, you can follow up on some of these things or reach me afterward by email. Any nonprofit that is interested can apply for a Redcap license. Redcap is an open source data management platform that connects with third-party applications like Twilio to be able to text patients their appointment reminders, pill reminders, um, or other ways of however you build it, whatever data you're interested in tracking or monitoring with your patients. And they actually are packaging their software to be available on the Amazon marketplace. So, and you won't, if you don't yet have Redcap or you're interested in using it, you don't have to apply for a license, install it on a web server from scratch. When it's on the Amazon web market, you can pretty much subscribe to its service um, in a much more user-friendly manner. So that's something to look out for too. Um, if you don't yet have platforms like it, I know that many clinics and hospitals use EMR systems like ParChart or Epic, which may have some built-in, texting capabilities. Um, not everybody uses, but if you don't have something like that and you are interested in texting platforms for your patients for retention, then these are options for you. and we could speak more about that if you're interested, and how to go about, setting that up and etc. Um, so I wanted to give you a couple examples of the differences between what Redcap can do versus what PrepMate can do. So Redcap is a very automated system where, once you've built it, it can automatically text your patients very simple questions like, that should, are you confirming for your appointment? And then please respond with a number um, for whether you are or you need to reschedule, uh, or even, just more general questions like just how is prep going for you, or whatever phrase or keyword you use. Uh, and then you can you can generate your staff can generate reports, your attention staff, and look at who they need to follow up with. That's kind of how Redcap would work. So it's not the like a natural language texting platform. It's more like survey oriented, survey based. Whereas with PrepMate, the way we built PrepMate was to mimic natural language. Um, PrepMate uses a database of phrases, many phrases, that it can recognize as affirmative or negative responses. So PrepMate users opt in, they create a username, a password, they opt in, and they choose the time of day and the frequency um, to receive daily pill reminders. Uh, and they get to choose what types of messages they want to receive. So do they want to receive messages that are explicit, did you take your prep today? Or they can choose other trigger phrases like um, for example, for this PrepMate platform, we built in jokes. So some people opt for jokes. So this system uh, texts them a joke, and the patient knows, oh, that's my daily pill reminder. So in terms of making the message more discreet, if someone is looking over someone's shoulder or looking at someone's phone or something like that. Um, and then we also built in check-ins, so weekly check-ins, where the PrepMate text platform would text patients, how are things going? And patients would reply, I'm fine, I'm well, etc. And then so the message just says, well, that's great. And that's all automated. The system does that without a staff person doing that. So there's literally no staff involved in that, except if the patient responds, I'm not doing well, I'm not okay, I'd like you to call me, I'd like you, etc. Then the system flags that for the staff to come back and call that person. Patients responded very favorably to the system, in particular because they were they had the power to change the frequency of the messages, and they could decide whether they wanted to stay in or opt out of the messaging. So when patients have the power to control those things, then it goes from a nagging text to a text that they want. Yeah, so those are some of the key differences between employing systems like these for visit, uh, patient clinic retention, but also pill, prep adherence. I also want to speak a little bit about the World Health Organization implementation tool for PrEP. And one of the modules, the third module, is for counselors. They cover a specific PrEP counseling style that your PrEP health education, health counseling staff you may be interested in training them in this counseling style. This is a counseling approach that we actually trialed in IPREX and the adolescent trials studies that I had mentioned earlier. So this comes out of that research where we took your traditional sexual risk reduction counseling and paired it with a medical or a medicine adherence um, techniques to come up with a a counseling session that integrated both of these, priorities in a timely way, in a natural way. The conversation flows, um, and it's useful to the patient, of course. So this is something that you may be interested in following up with as well for your counseling staff. Um, I also wanted to talk about, you know, I've been speaking about using social media marketing campaigns to do outreach online for PrEP for young people. And not every health department has a marketing uh, team or department, or maybe you're lucky if you have one person with some skills in this area. Well, the CDC and NIH have a lot of tools available online. This is coming from the National Cancer Institute. It's called the Pink Book, and they've put together a health communication planning guide that goes through 4 stages of planning a health uh, marketing campaign. As an example of something that they include in their guide, um, is this creative brief, which is really what you would, this would a marketer would know what a creative brief is, but I feel like in public health, it's not something we don't necessarily think the way marketers think, although we really should these days. Um, a creative brief is really, who are you creating this health messaging campaign for, and what is your goal of it, and have you done it in a way that is approachable to the your intended audience. So this is just some examples of what the guide goes through. They also have, so CDC has a clear communication index, which is like a survey basically, which has which allows marketing staff to review their own materials that they've come up with to make sure that they're really having the effect and reach that they're meant to have, um, as well as this health literacy online tool that is actually really meant for web pages and websites to go through. It's more or less a checklist to make sure that it's been built in a way that is going to make sense and work for the audience and that's going to be looking at it. Some additional tools I added toward the end of these slides is some topic guides on health communication and literacy, as well as some tools on web page or website templates that can be used, free of cost, and if you don't have people in your department to do this type of work, some of these things that are free and available and have been put together can help. So at the end, like really what I'm trying to make sure that I think folks start to realize that social media marketing, it can be a low cost, low effort strategy to achieve a high yield public health impact. It has been in our HIV prevention research studies, and I really hope that we can translate those experiences into the field and get more patients in clinic on PrEP. I think that's the goal. So that's it for me.
Thank you, Pedro, and thank you, Peter, as well for both of your presentations. We have a few questions from our audience. I'm going to start with the last one we got, which is on PrepMate. Is the tool available? It was created for the study. Is it available to use currently? And I think you touched on this, Pedro. I believe you said the San Francisco Department of Public Health is currently working on releasing the tool for agencies. Is that correct?
Yeah. So the EPIC study ended, and when it ended, we started looking at the efficacy of PrepMate, and clearly, as you've seen, we've come to the conclusion that it's worthwhile licensing out to other interested clinics. Before we begin licensing it out, there's some, kind of legal and finance questions that are being resolved, but we're going to demo it again. So since it was used in a research setting here at the Core Center in Chicago, we're actually going to scale it up to our full PrEP clinic, not just those who were participating in the research study, demo it, and then move forward with making it more widely available. But if you're particularly interested, I would suggest following up with Jonathan Fuchs. And I actually put his email in my slides in the notes, if you download the slides after.
Okay, perfect, thank you. Peter, we'll take the next question for you. Have you received direct guidance or suggestions from HRSA on the data entry in CareWare? Oh, sorry, I think okay, sorry, Peter, you were muted. Try it.
That's okay. We have not, but partially because we haven't sought it out. So we are funding all of the upstream activities. So for the 3 categories through rebates. So technically, we do not have to report to HRSA, but we have been using CareWare really for our own purposes because it's a tool that all of our vendors have. But so we haven't sought HRSA guidance.
Thank you. The next one is for Pedro, I believe. Could you touch on what you found or didn't on reaching out to and marketing to the down low population? Do you reach out to folks who don't identify as LGBTQ?
Well, so I can speak to it from actually our most recent work. Our latest project is a NIAID and NICHD funded research study called Keeping It Light. And so this is a 3,000 person cohort in Chicago that we're following for about 4 years. The goal of the project, we're tracking 13 through 34-year-old cis male, trans male and female, and genderqueer young people at risk for HIV. And we're marketing it as, with the goal of finding undiagnosed infections. We're marketing it as a HIV testing study, and we're actually mailing out at-home rapid tests for people to do themselves, with the goal of reaching people who would not normally walk into a clinic to test, or never have, or aren't sure how to go about it. In this study that we were funded in July, and so we just launched in the last half year. The goal is to find these people these individuals who may not identify as a gay man or a bi or queer man, or who may not necessarily consider themselves at risk. So I think it depends on how you market a study. If you or a campaign, if you market it as a study for gay men, down low may not participate. But if you market it as like a health education or health promotion campaign, more general audience campaign, then you may have better reach for people who do not identify that way.
Great, thank you. We'll do the next question for Peter. Could you talk about kind of the first steps to expand coverage for PrEP in terms of navigation and outreach? As you mentioned, the Upstream program in Maryland is pretty comprehensive, but for folks who are just exploring kind of that expansion, what would be a good first step?
So for us, my center really covers everything from diagnosis to viral suppression. Um, so we are not actually the PrEP implementers, which I think has given us the advantage of we are building outreach and linkage programs. So we are creating health navigation programs, and PrEP is an active component of that. So I think it's really important to start from where you are and build the outreach program that makes the most sense for you. If you have PrEP resources um, that are in the community, that's clearly something you want to build, but we're really careful to create a more inclusive program because we don't want to be PrEP evangelists, if you will. We don't want to come at people with, have you heard about PrEP? Can we get you on PrEP? It's much more about, hey, we're here to talk to you about your health needs and, you know, what's going on in your life that we could help with. So that's really how we've been building our outreach, our EIS, and our health education risk reduction programming is meeting people where they're at, and if PrEP is an appropriate intervention for them, we want to create that linkage. But it's not the first goal. It's part of the outreach. So we're basically building health navigation systems.
Great, thank you, thank you. You mentioned, Peter, in that you are trying to reduce the burden of data collection and how intrusive that is. I was wondering if you've been able to measure in any way how data collection can be a barrier or how it's impacted outcomes for the programs.
I think we're having very philosophical conversations around data collection for what's traditionally thought of as prevention programming. I think as we talk about undiagnosed individuals as Ryan White clients, um, which is tough for some people to get their minds around after 20 some odd years of HIV positive only. We start to move to if they are Ryan White clients and receiving that intensity of service, then they also then we have to collect data at that level. So it's more of a navigating the what's an appropriate level of service for the individual in front of you, and are we ready for engaging them from a Ryan White perspective, which sadly does have a higher administrative burden than many other programs.
Got it. Thank you. Thank you. Thank you. Pedro, the next question is for you. I was wondering if you could talk a little bit about the skills that staff should have for the kind of online outreach and retention activities that you discussed. Are there one or two key skills that you think staff should have?
So I think we're in an interesting place, and I spoke about this at the Biomedical HIV Prevention Summit this past December. But I think in looking at what is the traditional makeup of the public health team, we should now be including, folks coming out of the areas of health communication, as well as health informatics. But don't forget about creative design people with graphic design skills, with video skills, video editing, production skills that can generate and produce visually engaging media for your online and social media, advertisements and marketing. So that's what I would say. I think it's hard because most times you may not have funding for marketers, but if you can find, folks that are that have skills like that that they can bring to the team, I think that would be a boon to your team.
Thank you. We are just at time, so but before we wrap up, I wanted to give you both a chance to just ask if there was anything that that you wanted to cover before we wrap up. Okay. So with that, I just want to thank you again for being on the webinar. We are going to share your slides and the recording of the webinar in the next week. It's going to be posted on NASTAD's YouTube channel as well as on our online technical assistance platform. If you don't have an account already, you can email ontap@nastad.org and we'll get you set up. And with that, stay tuned for our next webinar. Thanks again to our presenters, and thank you all for joining us today. Have a good day.